Welcome to Chapter 6 of the BCSC Glaucoma series, Perimetry. In this lecture, we'll explore the essential principles of visual field testing and its critical role in diagnosing and monitoring glaucoma. From test strategies to interpretation of results, Chapter 6 offers the foundation needed to understand perimetry's power and limitations in the clinical management of this complex disease. Let's get started. Now, let's go over the key highlights of perimetry in glaucoma care. First, functional testing. The standard method used is white-on-white automated perimetry. This is the most commonly employed approach to assess visual function in glaucoma patients, as it provides a reliable way to detect and monitor visual field defects over time. Next, test reliability. A key consideration when reviewing a visual field test is its reliability. If the false positive rate is greater than 15%, the test is considered unreliable and should not be used to make clinical decisions. Interpreting abnormalities is all about ensuring that what you're seeing is real. Make sure any defect is repeatable, appears in the same location on future tests, and is not the result of an artifact like patient fatigue or poor fixation. Monitoring progression involves comparing the current results to a baseline. You're looking for new or expanded defects and whether the findings are consistent over time. Consistency and trend are key in deciding whether the disease is progressing. Lastly, trend-based analysis. This helps us estimate the rate of visual field loss. That rate can help predict a patient's risk of future functional impairment and guide how aggressive we need to be with treatment. Let's begin with a quick introduction to perimetry in glaucoma. The purpose of perimetry is to measure differential light sensitivity, essentially the eye's ability to detect light stimuli on a uniform background. This plays a critical role in glaucoma care in two main ways. First, to identify and quantify visual field abnormalities, and second, to monitor progression by estimating how fast functional loss is occurring. From a clinical standpoint, perimetry is valuable because it allows comparison of a patient's visual field performance against age-matched normal values. With repeated testing, we can begin to distinguish between stable disease and truly progressive functional decline. Moving on to the standard testing method, we rely on static automated perimetry using white-on-white stimuli, commonly known as SAP, or Standard Automated Perimetry. SAP has clear advantages. It standardizes both the way stimuli are presented and how responses are recorded, helping improve reproducibility. It also minimizes operator variability, which was more of an issue with older manual kinetic tests. Speaking of which, manual kinetic perimetry, like Goldman perimetry, is rarely used in glaucoma today, but can still be helpful in patients who can't complete automated testing. There are also automated kinetic perimetry systems available, though they're not currently validated for glaucoma management. This slide introduces the core principles of automated perimetry, beginning with standard automated perimetry, or SAP. SAP is the most widely used method to quantify both central and peripheral retinal light sensitivity in glaucoma patients. It determines threshold sensitivity by adjusting stimulus brightness, using ascending and descending intensities, and analyzing the patient's responses at each location. Next, we look at stimulus sizes. These are numbered I through V, with each step representing a four-fold increase in stimulus area. Size I is the smallest, at 0.25 millimeters squared. Size V is the largest, at 64 millimeters squared. Size 3, which is 4 millimeters squared, is the standard size used in the Humphrey Field Analyzer. Finally, we have the full threshold strategy. This starts by presenting a stimulus that gradually dims until the patient no longer sees it, then brightens again until it's detected. This confirms the threshold from both directions. While this method provides precise sensitivity thresholds, it's also lengthy and fatiguing for patients. Now, let's talk about light intensity and the decibel dB scale, which is central to understanding perimetry results. The Humphrey Field Analyzer tests light sensitivity over a dynamic range from 10,000 to 0.1 apostilbs, which spans 5 log units, or 50 dB. A 10 times change in light intensity corresponds to a 10 dB difference. If a patient cannot detect the maximum intensity stimulus at size 3, their value would fall below 0 dB, though a larger stimulus might be seen. At 30 dB, the stimulus is still visible despite being dimmed 1,000-fold, from 10,000 to 10 apostolbs, showing how sensitive healthy vision can be. Next, the biological relevance. Even small dB drops can correspond to substantial retinal ganglion cell loss, so changes on a perimetry printout shouldn't be dismissed lightly. The background light level in SAP is set to 31.5 apostolbs, which is bright enough to saturate rods, ensuring the test remains cone-mediated or photopic. Let's now go over the Swedish interactive thresholding algorithms, or SITAs, which are the most commonly used testing strategies in automated perimetry today. SITAs are based on Bayesian probability modeling, which uses population-derived data to estimate sensitivity at each test location. The algorithm creates a probability distribution function, PDF, for how sensitive a point is likely to be. As the patient responds to stimuli, the PDF is adjusted dynamically. It also factors in things like the patient's age, neighboring test point results, and prior responses. The benefits of SITA include shorter test times, up to a 50% reduction compared to full threshold strategies, lower or equal test-retest variability, meaning more reliable results. It's also widely implemented in the Humphrey Field Analyzer, the gold standard for perimetry in glaucoma care. Now comparing SITA Standard to SITA Fast. SITA Fast is quicker, but the trade-off is that it presents stimuli closer to the threshold. This might reduce test fatigue, but can be more difficult for the patient and less comfortable overall. Because of this, careful instruction and coaching during the test is essential to avoid reliability issues. Let's now continue with two additional strategies used in perimetry, SITA Faster and tendency-oriented perimetry, or TOP. SITA Faster. This is the most recent advancement in SITA technology and is about 30% faster than SITA Fast and around 50% faster than the traditional SITA Standard. The reduction in test time is achieved by using fewer reversals during threshold determination, modifying how stimulus intensity is presented, and eliminating false negative and fixation loss trials, which traditionally add to test duration. This all results in a much shorter exam, though it may come at the expense of some reliability, especially in certain patient populations. Tendency-oriented perimetry, or TOP, is another rapid thresholding strategy, but it's specific to the octopus perimeter by Haag-Streit. What makes TOP unique is it tests each location with only one stimulus, then supplements that result using data from adjacent test points, a type of spatial interpolation. This approach replaces traditional staircase methods, which can be time-consuming. As a result, TOP offers much faster test times, but again, there's a trade-off in precision compared to more rigorous methods like full threshold or SITA strategies. Let's talk about patterns of test points used in visual field testing, particularly for glaucoma. Most standard glaucoma tests are designed to evaluate the central 48 to 60 degrees of the visual field. The most common patterns used on the Humphrey perimeter are the 24-2 and 30-2 programs. On the octopus perimeter, you'll often see the 32 and G1 patterns. The numbers 24 or 30 refer to the radius of the test area in degrees, while the -2 indicates that the test points are offset 3 degrees from the horizontal and vertical meridians. This offset is intentional. It helps us distinguish glaucomatous defects, which typically respect the horizontal midline, from neurologic defects, which often respect the vertical. A typical example is the SITA Standard 24-2 test. This is widely used and employs the SITA thresholding algorithm while focusing on the central 24-degree field. Now, when we're dealing with advanced glaucoma or central field concerns, we switch to more refined patterns like the 10-2 on the Humphrey or the C8 on the octopus. These patterns concentrate on the central 20 degrees of vision with tighter spacing, Test points are placed every 2 degrees and offset slightly at the meridians to enhance precision. In patients with poor visual acuity or severe field loss, we can use a larger stimulus, size 5, to increase the likelihood of detection. Sometimes we combine size 5 with 10-2 testing if visual acuity drops below 2200. Lastly, peripheral testing strategies do exist to assess up to 60 degrees of field, but they're not commonly used in clinical practice. That's because results in the peripheral field tend to show higher variability, making them less reliable for monitoring glaucoma progression. This image is an excellent visual summary of the 24-2 visual field test pattern as it maps onto the retina. A few key points to reinforce from this slide. The 24-2 pattern tests the central 24-degree radius of the visual field. Test points are spaced every 6 degrees. Critically, each point is offset by 3 degrees from both the horizontal and vertical midlines. This offset helps distinguish glaucomatous defects, which typically respect the horizontal midline, from neurologic ones, which often respect the vertical. The white grid points shown are what the patient is actually tested on during the visual field exam. This figure anchors what we just reviewed and helps you visualize exactly why the -2 matters in test naming. Perimetry is considered a psychophysical test, which means the outcome relies on the patient's subjective perception and response to visual stimuli. Because of this, the accuracy and reliability of the results are influenced by multiple human factors. One major factor is patient attentiveness. A patient who is distracted, anxious, or simply not engaged during the test is more likely to produce inconsistent responses. The interaction with the technician, or the perimetrist, also plays a significant role. Clear instructions and reassurance can improve patient cooperation and focus throughout the test. Another key variable is the refractive status of the eye. If the patient isn't properly corrected for the testing distance, especially in presbyopic individuals, results can be falsely depressed. Similarly, pupil size matters. Overly constricted pupils can reduce retinal illumination and sensitivity. Ultimately, successful perimetry hinges on both the patient's performance and the perimetrist's guidance. Their combined efforts directly impact the validity of the results. This slide expands on how patient-specific factors affect perimetry quality. Attentiveness and fatigue are major variables. Attention can fluctuate between patients or even within the same patient across sessions. Longer test durations tend to exhaust patients, leading to less reliable results. Patients with cognitive decline, like those with dementia, may struggle to engage with the test accurately. Children can technically perform perimetry, but the normative data used for result comparison is based on adults. As a result, their findings must be interpreted with caution using adult-based criteria. The perimetrist plays a critical role in preparing and supporting the patient before and during visual field testing. Their guidance directly influences test quality. Before the test begins, they should clearly explain what the patient can expect, how long the test will last, when it's okay to blink, and how to respond to the stimuli. It's also important to reassure patients that the lights they're trying to see will often be very faint and that it's completely normal to miss more than half of them. That's expected, not a failure. This preparation helps reduce patient anxiety and increases cooperation, which leads to more reliable results. During the test, the perimetrist should continuously monitor the patient's fixation and head positioning, making adjustments or offering encouragement if needed. Even minor lapses in attention or alignment can affect the outcome, so active support is essential throughout the exam. Several technical factors can affect the accuracy of perimetry results. One key issue is uncorrected refractive error. If the patient doesn't have the proper near correction for the bowl distance, the visual stimuli can appear blurry, leading to artificially high threshold values. This is especially important for presbyopic patients, who often require additional near correction. Artifacts are another source of error. A common example is lens rim artifact, which occurs when the trial lens is poorly positioned. This can block peripheral test stimuli and mimic a visual field defect. Pupil size also plays a role. Small pupils, specifically less than 2.5 millimeters, can cause dimmer stimuli to be missed. While this used to be more common due to the use of miotic medications like pilocarpine, it's less of an issue today. Still, it's something to keep in mind during interpretation. This slide focuses on the principles behind evaluating visual fields. We begin with interpreting the results. Visual field testing is inherently subjective, despite advancements in algorithms that have improved consistency. Because of this, we must be cautious. Suspected defects or progression should always be confirmed on repeat testing before assigning clinical significance. Next is the evaluation framework. First, assess how reliable the test is. Were there excessive fixation losses or false positives? Then, determine whether the field is normal or abnormal based on expected patterns. Finally, look for any artifacts that could explain unexpected findings. Having a structured approach helps avoid overcalling disease and ensures we don't miss real progression. Let's take a closer look at how we assess the reliability of a visual field test. There are three main reliability metrics: fixation losses, false positives, and false negatives. Fixation losses reflect gaze stability. This is the least concerning of the three because it's more forgiving. Minor losses don't usually compromise the test's accuracy too much. False positives occur when a patient responds even though no stimulus was presented. This is the most damaging type of error, especially when the rate exceeds 15%. A field with many false positives may appear better than it actually is. False negatives are when the patient fails to respond to a bright stimulus. This can indicate poor attention, fatigue, or advanced disease. It doesn't always mean the test is unreliable, it just needs context. We detect fixation losses either by blind spot mapping or using gaze tracking. In the Humphrey reports, upward marks indicate tracking errors, while downward marks suggest the patient blinked. Understanding these indices helps us interpret the field with appropriate skepticism when needed. Now let's talk about false negatives and why they're not always as informative as we might think. False negative responses were originally thought to reflect patient inattention. If a patient missed a bright stimulus, it meant they weren't paying attention. But we now know that these rates often increase in patients with advanced visual field loss or those with highly variable, unstable fields. Because of their poor specificity, modern perimetry algorithms have actually stopped reporting false negative rates altogether. So what's the clinical takeaway? Don't overreact to high false negative rates, especially in patients with severe damage. Instead, focus on the false positive rate and fixation tracking, which give a much clearer picture of test reliability. Let's now go over how to interpret visual fields as either normal or abnormal. In a normal visual field, sensitivity is highest in the center and gradually decreases toward the periphery. This pattern is expected and evaluated using grayscale maps and the HFA data plots. When we suspect abnormality, we turn to deviation maps. Total deviation shows how much the patient's results differ from age-matched norms. Pattern deviation goes one step further. It adjusts for generalized depression, like what we might see from cataracts, helping us detect localized defects more accurately. Key indices on the report help quantify abnormalities. Mean deviation, or MD, tells us about overall sensitivity. A value between -2 and -6 decibels is usually considered mild to moderate loss. Pattern standard deviation, or PSD, reflects how uneven the field is. The more focal the damage, the higher the PSD, unless the damage becomes so widespread that everything is equally abnormal, which paradoxically makes the PSD improve. That typically happens when MD reaches about -12 dB or worse. Finally, the glaucoma hemifield test compares the superior and inferior halves of the visual field, helping flag asymmetry, which is common in glaucomatous damage. Now let's walk through the single field analysis report, which is a standard output from the Humphrey Field Analyzer. In the top left, we see the reliability indices. These tell us how trustworthy the test is. Fixation losses were 2 out of 15, which is acceptable. The false positive rate is 6%, and false negatives are at 13%. These values suggest the test is reasonably reliable. Moving to the raw threshold values labeled A, these are the actual sensitivity values in decibels measured at each point. On the right side is a grayscale representation. Darker areas mean lower sensitivity or worse performance at those points. Panel B shows the total deviation map, which tells us how much the patient's sensitivity differs from age-matched norms. This includes both diffuse and focal loss. Panel C shows the probability plot for total deviation. It highlights how statistically significant each reduction is, with darker boxes indicating higher levels of abnormality. Panel D displays the pattern deviation map, which adjusts for generalized depression. It makes focal defects easier to identify by removing global causes, like cataract. Panel E shows the pattern deviation probability plot, which is often more sensitive in detecting glaucomatous changes than the total deviation plot. At the bottom of the reliability section, we see the MD and PSD values. This patient has a mean deviation of minus 2.06 decibels, consistent with mild loss, and a PSD of 5.97, indicating localized damage. Finally, the glaucoma hemifield test result is flagged as outside normal limits, suggesting a suspicious asymmetry between the upper and lower fields. This slide covers the glaucoma hemifield test, or GHT. The GHT is designed to detect asymmetry between the upper and lower halves of the visual field, which is especially useful in glaucoma. Glaucomatous damage often presents as localized loss in just one hemifield, so this comparison can be very telling. Here's how it works. The test divides the field into 5 zones in the superior hemisphere and compares each to its mirror image in the inferior field. This is done using pattern deviation probability plots, not raw or total deviation data. The analysis looks for statistically significant differences between these paired zones. If there's a mismatch, that could point to glaucomatous damage. There are 3 possible outcomes. The result can be within normal limits, borderline, or outside normal limits, that last one being strongly suggestive of glaucomatous change. One important clinical point is that while the GHT is sensitive, it's not very specific. That means it can flag defects in cases where something else is going on, like optic neuropathies or just poor test reliability. Let's talk about what qualifies as an abnormal visual field. According to the Ocular Hypertension Treatment Study, a field is considered abnormal if less than 5% of the normal population would show similar results. Another marker is if the glaucoma hemifield test result falls outside normal limits. But the key is repeatability. These findings must be seen in 3 consecutive, reliable visual fields to be considered valid. We also use what's called the cluster criterion. This means there are at least 3 neighboring abnormal points on the pattern deviation plot, and at least one of those has to be significant at the 1% level. This pattern helps confirm that we're seeing a true defect, not just a random artifact. This combination of repeatability and clustering improves our confidence that a defect is real and clinically meaningful. This slide focuses on common artifacts that can distort visual field test results and potentially mislead interpretation. One of the most frequent issues is lens rim artifact, which occurs when a decentered trial lens blocks peripheral light, mimicking a peripheral field defect. Incorrect refractive correction, especially in pseudophakic patients, can lead to generalized depression across the field, reducing overall sensitivity without representing true pathology. Eyelid artifacts are another common pitfall. For example, a drooping eyelid, ptosis, can cause an artificial superior defect by obstructing light from entering the eye. Similarly, the cloverleaf pattern arises in inattentive patients who respond only during the early phase of testing and stop midway. This results in a pattern of preserved sensitivity in the central test points but diffuse loss elsewhere, mimicking neurologic or widespread disease. False positives, particularly rates about 15%, can make the field appear better than it actually is. These patients respond when no stimulus is presented, which can mask true scotomas. Pattern reversal is a more subtle artifact. This happens when pattern deviation looks worse than total deviation, which seems paradoxical. It typically reflects an artificial enhancement of focal loss due to false positives, although in rare cases it may indicate early paracentral glaucomatous damage. This slide demonstrates the classic appearance of a lens rim artifact. On the left, we see a visual field that appears to show widespread peripheral loss, but this is actually due to incorrect lens positioning. The peripheral light was blocked by the edge or rim of the corrective lens, creating the appearance of diffuse field loss. 9 days later, the test was repeated, shown on the right. This time, the corrective lens was properly centered. The artifact resolved and the field appeared significantly improved, revealing the true visual sensitivity. This slide shows a classic example of the cloverleaf artifact, which reflects poor test reliability. The Humphrey Field Analyzer begins by testing 4 primary central points, 1 in each quadrant, and then moves outward. In this case, the patient responded well to those initial points, but then became inattentive and stopped responding as the test continued. As a result, only the central points appear normal, while the rest of the field shows diffuse loss. The resulting grayscale resembles a cloverleaf pattern, hence the name. It's important to recognize this artifact, as it may be mistaken for severe glaucomatous loss if not interpreted in context. You'll also notice extremely high false negatives and long test duration, further indicating low patient reliability. This slide illustrates a classic example of high false positive artifact. In the top field, the patient has a falsely elevated sensitivity. These are the so-called white scotomas, areas where the patient reports seeing stimuli at intensities beyond what's physiologically possible. This typically results from patients pressing the response button even when no stimulus is presented. As a result, the visual field appears overly healthy, which may mask true defects or give an artificially high baseline. 3 weeks later, after clear instruction to respond only when a stimulus was seen, the bottom test shows a more realistic field. The superior arcuate loss now becomes visible. This emphasizes how excessive false positives, especially above 15%, can make glaucomatous damage harder to detect. This slide highlights pattern reversal artifacts, which can cause artificial improvement in the pattern standard deviation, or PSD. This typically results from a high false positive rate. Let's take a look at the examples. In the top row, labeled A, we see a normal total deviation plot. However, the pattern deviation plot shows isolated defects. This discrepancy is a red flag. In the bottom row, labeled B, the pattern deviation plot actually appears worse than the total deviation plot. This creates the illusion of localized damage when in fact the defect may be diffuse. This pattern reversal can mislead the clinician by suggesting a focal loss that isn't truly there. The key teaching point is that pattern deviation should not appear worse than total deviation. When it does, think about possible artifact and confirm findings with repeat testing and clinical correlation. While pattern reversal is often an artifact, there are cases where it reflects true early disease, especially in the paracentral region. Studies like Chang et al., Ophthalmol Glaucoma, 2022, have shown that early paracentral scotomas may not significantly lower the overall total deviation values if the rest of the field is normal. This skews the subtraction process used to generate the pattern deviation plot, causing it to highlight the small focal defect much more dramatically. These isolated paracentral defects can appear only on the pattern deviation plot, particularly in patients with normal tension glaucoma, myopic eyes, or eyes with early asymmetric disease. When these findings are repeatable in location and shape across multiple tests, it increases the likelihood of true pathology and not artifact. So don't dismiss a paracentral defect as noise. In the right context, it may be the first sign of early glaucomatous damage. In glaucomatous disease, the loss of retinal ganglion cell axons at the optic nerve head leads to characteristic patterns of visual field loss. These field defects often correspond directly to areas of neuroretinal rim thinning observed on exam or imaging. There are several classic patterns we look for. Arcuate or biramscotomas. These arc from the blind spot into the nasal field and follow the RNFL pathway. Nasal step. A sharp horizontal step in the nasal field due to damage near the horizontal raphe. Paracentral scotomas. Located near fixation, these may appear early in glaucoma, especially in normal tension cases. Altitudinal defects. Involve the entire superior or inferior hemifield and are more advanced. Generalized depression. A diffuse reduction in sensitivity, which is rare in glaucoma unless there's also media opacity or very advanced disease. And finally, temporal wedges. These are uncommon but may appear with damage near the temporal disc. Understanding these patterns is essential for diagnosing and monitoring progression of glaucomatous visual field loss. This next slide highlights key points about how visual field defects are plotted, which anatomical regions are most susceptible, and how vision tends to be preserved even in later stages of the disease. When we talk about visual field defects in glaucoma, it's helpful to remember that the names, like arcuate or nasal step, originally come from kinetic perimetry. But most testing today is done with static perimetry, like the Humphrey Field Analyzer, which plots sensitivity at discrete points on a grid. This means that arcuate defects don't look like smooth arcs on a printout. Instead, they appear as clusters of depressed points, something we have to interpret visually. Now, anatomically, the superior and inferior poles of the optic nerve are the most vulnerable to glaucomatous damage. When axon loss is scattered and mild, it can lead to a generalized sensitivity decrease. But when arcuate damage occurs in both hemifields, we may see double arcuate defects, which can result in significant peripheral field loss. Finally, it's worth noting that even in advanced disease, a central island and the inferotemporal visual field often remain preserved. This preservation is critical for functional tasks like reading, recognizing faces, and navigating safely. This slide visualizes how damage to specific regions of the optic nerve translates into predictable patterns on the visual field test. On the left, we see the anatomy of an arcuate scotoma. The red-shaded region highlights retinal ganglion cells served by axons that pass through a damaged region of the optic nerve. This arcuate pattern typically begins 10 to 20 degrees from fixation and follows the path of the retinal nerve fiber layer, arching from the blind spot toward the nasal field. The corresponding visual field shows a classic arcuate defect, a crescent-shaped zone of relative loss in the superior nasal field, matching the distribution of the damaged fibers. On the right, we see the anatomy of a nasal step. This occurs when there's a discontinuity in axonal loss across the horizontal raphe, often due to damage of superior fibers serving the infranasal retina. That leads to a field defect along the nasal horizontal meridian. In kinetic perimetry, the nasal step is defined as a depression in one horizontal hemifield compared to the other. In static testing like the Humphrey 24-2, it appears as an abrupt drop in sensitivity across the nasal midline. Now let's look at two additional patterns of field loss that often reflect early and advanced stages of disease respectively, the paracentral scotoma and the altitudinal defect. Let's begin with the paracentral scotoma, shown in Figure 610. This type of field defect represents an island of vision loss within 10 degrees of fixation, typically in the supraronasal field. It often results from damage to the inferotemporal retinal nerve fibers, which enter the inferior pole of the optic nerve. These scotomas are especially important because they may be the earliest sign of glaucomatous damage and are particularly common in patients with normal tension glaucoma. The visual field example here shows a small focal defect that can easily be missed if one focuses only on total deviation plots. Next, we have the altitudinal defect in Figure 611. This is defined by nearly complete loss of an entire horizontal hemifield, in this case, the superior half. Altitudinal defects usually reflect more advanced disease with extensive axonal dropout. This pattern is often associated with moderate to severe glaucomatous optic neuropathy and should prompt careful clinical correlation with optic nerve appearance and other risk factors. This slide introduces the key goals and challenges of interpreting serial visual field tests. When interpreting serial visual fields, our primary objectives are twofold. First, we want to determine if a change represents true progression versus normal test variability. And second, we need to assess whether that change is due to glaucomatous or another cause entirely, like optic neuritis, stroke, or other pathology. But this process is not always straightforward. Visual field testing is inherently subjective, influenced by patient fatigue, attention, and testing conditions. Even in stable disease, some variability between tests is expected. That's why one of the most important clinical skills in field interpretation is learning to distinguish expected fluctuation from meaningful deterioration. To detect progression, we rely on two main approaches. First is event-based analysis, which compares current visual field tests to a baseline. If the follow-up tests are statistically worse, that suggests progression. GPA software, guided progression analysis, is a common tool for this. Second is trend-based analysis, which looks at the rate of change over time. This method helps us estimate how quickly the field is worsening and allows us to adjust treatment intensity based on individual risk and life expectancy. One common tool for tracking progression is the mean deviation trend. It's simple and widely used, but it can be affected by cataracts or other media opacities. A decline may suggest disease worsening. However, variability is a major challenge. False positives and negatives are common. The OHTS study showed that 66% of patients who seemed to progress after 2 tests later tested normal. But with 3 tests, this dropped to only 12%. Takeaway: don't rely on a single test. Multiple tests are needed to confirm true change. GPA is an event-based tool that compares follow-up tests to 2 baseline exams. It uses pattern standard deviation to adjust for media opacities. A 3-point change flagged once is possible progression, and if it's repeated twice, it's likely. False positives can range from 19% for possible to 7% for likely. VFI shows the percent of field remaining, with more weight on central vision. It's less affected by cataracts and can help project field loss over 5 years. Octopus Eye Suite calculates the mean defect change per year and evaluates both point-wise and cluster-based progression. It uses linear regression to detect change over time, either at specific test points or across nerve fiber zones. In summary, it offers statistical tools similar to HFA's MD and GPA and supports both detailed point tracking and regional trend analysis. When monitoring for progression, test frequency plays a critical role. Accurate detection is often limited by the inherent variability of visual field testing. To reliably spot new defects, we need consistent, high-quality follow-up exams. That includes both how often we test and how well the tests are performed. The takeaway here is important. If testing is too infrequent or poorly timed, we miss signs of worsening disease until it's too late. When choosing a visual field testing pattern, 24-2 remains the standard for most patients with glaucoma. The 10-2 test provides denser sampling in the central 10 degrees, but current evidence does not show a clear advantage over 24-2 for tracking progression. A newer hybrid strategy, the 24-2C, adds 10 test points centrally and is available on the Humphrey Field Analyzer. While promising, its clinical utility is still being evaluated. Ultimately, the choice of test should be individualized, taking into account the patient's risk of progression, their ability to tolerate testing, and whether detailed central visual field data is necessary. In addition to standard automated perimetry, several alternative perimetric tests have been developed to detect glaucomatous damage earlier in the disease course. These include FDT, SWAP, and FDF, all of which are designed to target specific retinal ganglion cell subtypes or visual pathways, such as those responsible for motion, contrast, or color. The idea is that early glaucoma may selectively affect certain cells, particularly those projecting to the magnocellular pathway, before broader damage occurs. However, whether this preferential vulnerability is consistent across patients remains uncertain. These tests may pick up subtle dysfunction before standard testing does, but clinical adoption remains limited. Although alternative perimetry aims to detect early glaucomatous changes, these methods come with limitations. No test is completely specific to one visual pathway, and early glaucoma doesn't always target a single type of retinal ganglion cell. Subjectivity and variability can reduce test reliability over time. There are also other functional tests like contrast sensitivity, flicker sensitivity, and microperimetry, but these are not commonly used in clinical glaucoma care. Tools like visual evoked potentials and multifocal ERG are typically reserved for research or neuro-ophthalmic evaluation. That wraps up our overview of visual field testing in glaucoma. If you'd like to see how a standard Humphrey visual field test is actually run, check out the video linked in the description. Thanks so much for watching.